Hi, my name is Charles Kahi. I'm Associate Professor of Clinical Medicine at Indiana University School of Medicine and Gastroenterology Section Chief at the Raudebush VA Medical Center in Indianapolis, Indiana. We will be presenting today our study, Impact of a Quarterly Report Card on Colonoscopy Quality Measures. Colonoscopy, as you know, has a pivotal role in the prevention of colorectal cancer. However, recent studies have raised concerns that screening colonoscopy is less effective in decreasing colorectal cancer incidence and mortality in the proximal colon compared to the distal colon. The quality of colonoscopy performance, reflected in surrogate measures such as the adenoma detection rate and the cecal intubation rate, is a critical factor. Studies have shown that adenoma detection is highly variable among different endoscopists, and individual endoscopists' adenoma detection rates are independent predictors of the risk of interval colorectal cancer after screening colonoscopy. Education and monitoring of validated colonoscopy quality metrics are necessary components of any intervention aimed at correcting the problem of variable quality of colonoscopy. However, the impact of monitoring and intervention on colonoscopy quality metrics is unclear. The American Society for Gastrointestinal Endoscopy has recently introduced a quality recognition program which recognizes endoscopy units that have implemented quality improvement and monitoring processes as an integral part of their operation. In 2009, the Richard L. Raudebush VA Medical Center in Indianapolis GI endoscopy unit was one of the first to receive this distinction. The transition to the new quality monitoring program occurred during the first 3 months of 2009. Subsequently, physicians who performed endoscopic procedures at the Raudebush VA Medical Center started to receive quarterly report cards, which provided data regarding colonoscopy quality indicators, including documentation of bowel preparation quality, pre-procedure patient assessment, cecal intubation, withdrawal time, and adenoma detection rate. The data are derived from the endoscopic and clinical electronic databases at the Raudebush VA, tabulated and provided to the entire group anonymously by the GI section chief. Each physician then receives their own data confidentially, with the rest of the data de-identified, so that she could compare their performance to the rest of the group. To our knowledge, there are no studies assessing the impact of such a comprehensive reporting and intervention strategy on the performance of colonoscopy. The aim of this study is to determine the effect of this intensive and regular monitoring and feedback program on the quality of colonoscopy performance among a group of academic gastroenterologists at a tertiary university-affiliated VA medical center. We will briefly review the study methods. We reviewed average risk colonoscopies performed from July 1st, 2008 to December 31st, 2008, which constituted the pre-intervention phase, and from April 1st, 2009 to March 31st, 2011, which constituted the intervention phase. The report card quality initiative was set up and implemented gradually during the first few weeks of 2009. To minimize the variability due to inconsistent recording of data when the initiative was first introduced, we defined the first 3 months of 2009 as the implementation phase and did not include data recorded during this time period. Eligibility criteria were average risk screening colonoscopies in patients aged 50 years and older and first colonoscopy in at least 5 years. We performed logistic regression adjusting for physician, patient age, and patient sex, and we used this to compare the adenoma detection rate, advanced neoplasm detection rate, serrated polyp detection rate, and cecal intubation rate between the 2 phases of the study, and to obtain estimates and 95% confidence intervals. We will present the results now. During the study time frame, a total of 928 average risk patients underwent an eligible screening colonoscopy performed by 6 attending physicians. The majority of the patients were male, 93%, and 78% were Caucasian, with a mean age of 59 years and mean body mass index of 30.5. There were 336 pre-intervention colonoscopies and 592 during the intervention phase. There were significantly more Caucasians in the intervention phase, 81% versus 73%. However, there were no significant differences in patient age, gender, smoking status, body mass index, bowel prep quality, and proportion of colonoscopies performed with the trainee between the pre- and intervention phases. As you can see in Table 2, several outcomes are listed. the adenoma detection rate and cecal intubation rate were both significantly higher in the intervention phase. The adenoma detection rate increased from 44.7% to 53.9%, while the cecal intubation rate increased from 95.6% to 98.1%, both of which were statistically significant. Most of the increment in the adenoma detection rate was due to increased detection of proximal adenomas, which increased from 29.3% to 39.8%. However, distal adenoma detection did not change significantly. Likewise, there were no significant changes in advanced neoplasm detection rate, serrated polyp detection rate, number of adenomas found per colonoscopy, or mean size of adenomas after implementation of the intervention. When the results were examined by physician, 5 of the 6 physicians' adenoma detection rates increased from the pre-intervention to the intervention phase. However, none of the increases were statistically significant. Increases in the detection of proximal adenomas were observed for all 6 physicians, although statistically significant for only 2. All of the physicians' cecal intubation rates increased from the pre-intervention to the intervention phase. However, none of the increases were statistically significant, which should not come as a surprise given the relatively small sample sizes of the subgroup analyses. On multivariable logistic regression, the adenoma detection rate was significantly increased with age, male gender, and the intervention itself. The odds ratio for the intervention was 1.45 with 95% confidence intervals 1.08 to 1.94. This study is important because it was conducted within a group of endoscopists at a university-affiliated VA medical center, and it showed that a quarterly report card was independently associated with improved colonoscopy quality indicators. The overall adjusted adenoma detection rate for the 6 endoscopists increased from 44.7% to 53.9%, while the cecal intubation rate increased from 95.6% to 98.1%. An important finding is that the overall increment in adenoma detection was due mostly to an increased detection of proximal colon adenomas. Previous studies assessing the effect of colonoscopy quality interventions have yielded inconsistent results. Our study differs from previous research in several aspects. Our report card initiative is based in an academic setting and involves a relatively small group of endoscopists, and there were no financial incentives nor penalties for achieving or not achieving preset targets. Furthermore, the report cards are blinded to individual endoscopists with minimal feedback administered confidentially as needed, and the intervention is administered relatively frequently at 3-month intervals. One potential advantage of our report card system is practicality. The reports are relatively straightforward to generate with minimum effort and data mining, and it is relatively easy to replicate and use in a variety of clinical settings, and is also likely to be easily understood and accepted by clinicians. In conclusion, a quarterly report card was associated with improved colonoscopy quality indicators. This intervention is practical to generate and implement and may serve as a model for quality improvement programs in different patient and physician groups. However, additional work is needed to determine whether this intervention is effective in different practice settings and whether its beneficial effects are sustained.